This is Lorraine Sarreal, acute care nurse practitioner. I am adjunct clinical faculty at UTHealth, Houston. I currently work at HCA Houston Clear Lake with neurosurgery. Brain atrial venous malformation, or AVM, is a tangle of abnormal blood vessels connecting arteries and veins in the brain. The arteries take oxygenated blood from the heart to the brain. Veins carry oxygen-depleted blood back to the lungs and heart. A brain AVM alters this process. Normally, your heart sends oxygen-rich blood to your brain through arteries. The arteries slow blood flow by passing it through a series of progressively smaller networks of blood vessels, ending within the smallest blood vessels called capillaries. The capillaries slowly deliver oxygen through their thin, porous walls to the surrounding brain tissue. The arteries and veins in an AVM lack the supporting network of smaller blood vessels and capillaries. Instead, the abnormal connection causes blood flow quickly and directly from your arteries to your veins, bypassing the surrounding tissues. The cause of AVMs are not clear. Most people are born with them, but occasionally form in later life. They are rarely passed down among families genetically. A rare 1% of the population are affected by brain AVMs. True AVMs are congenital shunts between the arterial and venous systems. AVMs vary in size. They can be as small as a few centimeters or large and tortuous, causing a shunt of blood large enough to increase cardiac output and cause heart failure. AVMs occur most frequently in the cerebral hemispheres, brain stems, and spinal cord. The most common ones occur in the posterior part of the hemispheres, extending from the cortex to the ventricles. They affect males more frequently than females. They're rarely hereditary, and symptoms usually appear between ages of 10 to 30, occasionally in the 50s. There are multiple signs and symptoms that an AVM can cause, depending on the location of the AVM. For a non-ruptured AVM, the hemorrhage rate is about 2 to 4% per year. One half of AVMs rupture and are initially seen as an intracranial hemorrhage on a CT head without contrast. Unlike aneurysmal subarachnoid hemorrhages, there is usually no vasospasm. A ruptured AVM comes with a 17% rate of rehemorrhage, at least within the first year. AVMs can result in reduced oxygen to the brain tissue. They can cause weak vessel walls, resulting in aneurysms, and brain damage can occur as the AVM grows, causing compression on the brain. When a patient presents to the ED with neurological symptoms, the first thing we get is a CT head without contrast. If there is a suspicion for an AVM, further diagnostics can include an MRI of the brain, but the gold standard in diagnosing an AVM is a cerebral angiogram. Click on the YouTube links below to see a quick angio. Because of the increased blood flow to the AVM, treatment varies case by case, but typically treatment is done in stages. Depending on how large the AVM is, 2 to 3 neuroendovascular embolizations are done, decreasing the size of the AVM as well as decreasing the risk of hemorrhage intraoperatively. The last step is surgical resection of the remaining AVM. Because of the weak vessels of the AVM, an aneurysm was found. The neuroendovascular radiologist did not have a long enough catheter to reach that aneurysm, so the case was aborted. Strict blood pressure control was maintained, and patient was allowed to recover. Because of the seizures post-op, neuroendovascular and neurosurgery decided to let the patient recover from this visit and ensure no further seizures.
The patient is due to follow up in 3 to 4 weeks to plan for surgical resection of the remaining AVM.